Pancreas is for glucose regulation. Insulin and glucagon, its two hormones, are produced inside the islets of Langerhans cells in the pancreas. Insulin targets the liver, muscles, and all other cells. It's released after a meal to lower glucose levels in the blood. It does this by increasing all cells' permeability to glucose, so cells can take in the glucose if insulin is present. Glucose is converted to glycogen in the liver and the muscle cells, so the liver and muscle cells store glucose as glycogen for energy needed later on. Glucagon is released because your glucose is gone. If you have low blood sugar, then the pancreas releases glucagon, which targets the liver. And this is after you haven't eaten for a while, and it raises glucose levels in the blood. In other words, glycogen is converted to glucose in the liver. These two hormones have the opposite effect, so they are antagonistic. Glucose is a sugar. Anything ending in ose is a sugar, like sucrose, fructose, lactose, deoxyribose. Glucagon is released when your glucose is gone, when you have low blood sugar. And glycogen is the storage form of glucose. Let's draw the negative feedback loops for both insulin and glucagon. So high blood sugar following a meal means the pancreas or islet cells are going to release insulin, which goes to the liver, muscles, and all cells. Glucose is converted into glycogen, and once the blood sugar has decreased, the pancreas decreases the production of insulin. Low blood sugar following fasting causes the pancreas to release glucagon, which goes to the liver, to convert glycogen back into glucose until blood sugar levels have increased, reaching homeostatic levels and turning down the production of glucagon from the pancreas. Diabetes mellitus is a genetic disorder where not enough insulin production due to deterioration of beta cells within the islets of Langerhans. The result is high blood sugar levels after eating, called hyperglycemia. Glucose can appear in the urine. Normal urine contains no glucose. Glucose also draws water from the body, so someone with diabetes mellitus has large volumes of urine. Symptoms of diabetes include frequent urination and constant thirst, low energy levels because the person cannot take the glucose into their cells to make ATP. Lots of sugar in the blood, but little moves into the cells. The person starts breaking down fats and proteins for energy, and they may have sudden weight loss because of this. This is a little boy before and after insulin treatment. Before, he was breaking down his own muscles and fat for energy. After, he was able to put on some weight. If a person is on insulin injections, they need to check their blood glucose 8 times a day and inject themselves with insulin about 5 times a day. With each injection, they have to eat a certain amount. The insulin pump is a newer technology. It has continuous monitoring and secretes a baseline insulin constantly. After eating, the person has to enter the amounts of carbohydrates, and the pump will administer a higher level of insulin. There's 2 types of diabetes mellitus. Type 1 is due to degeneration of islet cells. So the islet cells are broken down. This is an autoimmune disease. Treatment is insulin injections. Type 2 is due to decreased insulin production or resistance to insulin. Treatment can include exercise, weight loss, eating well, oral drugs, or insulin. So what's the difference? Type 1, the body cannot produce the insulin it needs. The incidence is growing steadily. It's usually diagnosed in children or young adults, although anyone of any age could get type 1. Causes are unknown, but it develops when the immune system attacks insulin-producing cells. The symptoms appear suddenly and must take insulin daily. Type 2 diabetes is when the body produces too little insulin and/or is unable to respond to it. The incidence is rising at an epidemic rate. Healthy diet, regular physical activity, maintaining a normal body weight, and avoiding tobacco use can prevent or delay the onset of type 2 diabetes. Risk factors include advancing age, obesity, poor diet, family history of type 2 diabetes, physical inactivity, or ethnicity. A note about the ethnicity: some populations are at higher risk of type 2, such as those of South Asian, African, Hispanic, or Aboriginal descent, those who are overweight, older, or have low income. Diabetes rates are 3 to 5 times higher in First Nations. The symptoms of type 2 often appear gradually. It's often managed by exercise and a healthy diet or oral medication. If the condition progresses, it can be treated with insulin. Impact of diabetes in Canada. Diabetes complications are associated with premature death. It's estimated that 1 in 10 deaths in Canadian adults was attributable to diabetes in 2008 and 2009. People with diabetes are over 3 times more likely to be hospitalized with cardiovascular disease, 12 times more likely to be hospitalized with end-stage renal disease, that's kidney disease, and over 20 times more likely to be hospitalized for non-traumatic lower limb amputation compared to the general population. So type 2 diabetes is the result of many factors. It is not one thing that causes it. So too much food with too much animal fat, not enough exercise, one set of genes inherited from parents that makes you hungry, another set of genes causes greater insulin resistance. A person who's overweight needs extra insulin as body becomes resistant. Fatty deposits in pancreas cause even more damage. Another set of genes inherited from parents make islet cells in pancreas wear out early, so cannot produce enough insulin. Result, the body needs more insulin, but cannot produce it, so they have type 2 diabetes. Islet transplants can reverse the effects of diabetes. The U of A is a leader in islet transplants. U of A Hospital was the first to successfully transplant islets of Langerhans cells into a patient. Islet cells are taken from 2 cadavers and transplanted by injection into the patient. They need to have 2 pancreas donations per operation to have enough viable islet cells for the transplantation. So islet transplants are often done by taking the pancreas from the donor. They remove the islet cells. They put the islet cells into a syringe, and then in the recipient, the islet cells are put into the portal vein leading to the liver, because the liver has a huge blood supply. So those islet cells would get lots of oxygen right away. The leader in the world for islet cells transplants is Edmonton, and it's called the Edmonton Protocol. James Shapiro is the head of the team that leads this, and they are doing more studies on islet cell transplants, like developing a new site for islet transplantation under the skin, which they believe will offer less risk and far greater health benefits for patients. So challenges and controversies: who receives islet cell transplants? It would be those that are healthier, they don't smoke, younger individuals, someone who is more sensitive to fluctuating insulin levels in their, glucose levels in their blood. Where do we get adequate donor tissues? Neonatal pigs, stem cells, engineered beta cells, K cells in the gut. Can we improve the survival rate of transplanted cells, in which case we wouldn't need 2 cadavers? How do we reduce or eliminate the need for immunosuppressants and related side effects? Let's compare diabetes mellitus and diabetes insipidus. Mellitus is the lack of insulin, and insipidus is the lack of ADH. There's lots of glucose excreted in urine, and water follows by osmosis, which means lots of urine produced in diabetes mellitus. In insipidus, the lack of ADH means that the person cannot reabsorb water from the kidney, so also produces lots of urine. In both cases, urine would be dilute because of the large amount of water in it. Let's review all the glands and hormones that contribute to glucose levels in the blood, starting with the pancreas. Insulin causes glucose to glycogen conversion in the liver, so it decreases blood glucose. Glucagon causes the conversion of glycogen to glucose in the liver, so increases blood glucose. Cortisol from the adrenal cortex increases amino acids in the blood, which go to the liver to be converted to glucose, so increases blood glucose. The adrenal medulla releases epinephrine, which causes the conversion of glycogen to glucose in the liver, so increases blood glucose.